Hi all, in this video we are going to be looking at treatment and recidivism of sex offenders, and this is the last topic that wraps up this chapter on sexual dysfunctions and sexual deviations. So we'll begin with what recidivism is. Recidivism is the tendency of a criminal to re-offend. That is, a person who, after having faced negative consequences for his undesirable behavior, or who after having been trained to extinguish an undesirable behavior, repeats the same undesirable behavior. Like for example, a person who has committed a sex crime on a child can re-offend the same crime even after having faced a jail sentence. It can be seen also as the percentage of prisoners who are re-arrested for a similar offence. Okay, so when I say recidivism is a percentage of prisoners who are re-arrested for a similar offence, that leaves us with a very important question as to how do we protect the society from such sexual predators. Can we cure them, or are they typically incurable? Should they receive life sentences on the presumption that they are bound to offend again, or have they been unfairly singled out by media sensationalism even though they are really responsive to treatment? Because we are hearing a lot of real life case studies or news about how people who after having served their jail sentence come back to commit the same sex crime again. So to understand and answer the questions, we need to look at the treatment options that are available for sex offenders, and also to see the effectiveness of these treatment procedures. So with this in mind, we move on. Okay, before I go into the specific therapeutic techniques, I will look into some facts. One is, sex offender recidivism is actually markedly lower than many other kinds of sex crimes. That is, people who commit sex crimes tend to not offend as high as those who are involving in other kind of crimes. But however, you need to understand that sex offenders with certain kind of sexual preferences have very higher rates of recidivism. That is, they tend to re-offend. Among those are people who have severe sadism, and those who are attracted to children, people who have preference for sadistic and coercive sex, and these are very strongest predictors of recidivism. Other predictors include negative social influence, poor cognitive problem solving, and loneliness. On a positive note, with age, the recidivism rates for rapists and other paraphilic sexual preferences generally come down, and this is something that we have seen in our earlier videos as well. Okay, psychotherapy for sexual offences has one of the goals. The first thing is to modify patterns of sexual arousal and attraction. Like for example, a foot fetish may show sexual arousal for a women's footwear, which is generally not considered to be sexually attractive. So modifying sexual arousal, patterns of sexual arousal is very important. Or is showing sexual arousal for child. These are the areas that we need to look at. The other thing is to modify cognitions and social skills in order to allow more appropriate social interaction with adult partners. As I told you, many rapists try to read sexual connotation into otherwise neutral or negative messages of women. So it's we need to help them decode and interpret the messages that are coming from a woman in a social conversation. That is, like for example, let's say a woman is having a friendly conversation, it should be read or it should be received only as a friendly conversation. It cannot be seen to have a sexual motivation. The third is to change habits or behaviors that increases the chances of reoffending. Like for example, let's say the person has impulsivity or has an antisocial history. Then look at ways in which you can change those behaviors, and to reduce the overall sex drive, the urge or the craving for sex. Aversion therapy, I think we looked at aversion therapy even when we did fetishistic disorder. This involves pairing a paraphilic stimulus with an aversive event such as a forced inhalation of a noxious odor or a shock to the arm. Apart from this electrical shock or the electrical conditioning, a person is also made to imagine an aversive event while viewing a paraphilic stimulus. In a variation of this covert sensitization technique, which we call as the assisted covert sensitization, in the setting, a foul odor is introduced to induce nausea at the point of peak arousal. Like for example, the patient may be asked to masturbate to fantasies of a paraphilic stimuli, but at the point of ejaculatory inevitability, the person is asked to shift the themes to normal or appropriate sexual themes. This is replaced with pairing a pleasurable stimuli of orgasm with fantasies that are more appropriate, that is, which involves sex between two consenting adults. Aversion therapy has been shown to be very effective in laboratory, but how well it generalizes into the patient's outside world is uncertain, and especially so when the motivation of the patient wanes. The other therapeutic techniques are what we call as cognitive restructuring, because they play a very central role in sexual abuse. Like for example, an incestuous father may say that had the child said no, he would have stopped. So when he is making a statement of that kind, there are a lot of implied negative distortions. One thing that he is assuming is that the child is capable of giving a consent to the sexual act, which the child is not. The other thing that that he is assuming that is a child who has said no is saying an yes to the act, which need not necessarily be the case. The other thing is the other distortion that can be present is that the child is responsible for stopping the act, which again is not is not true. So helping the patients identifying cognitive distortions and helping them to replace with healthier ones becomes very important. And the other important component is your social skills training. Training here typically involves interaction of the perpetrators with a female partner who can give offenders feedback on their responses to the interaction. So just because a woman is continuously refusing to the sexual advances made by a particular male, it doesn't mean that she's playing hard to get. She simply is averse to such sexual advances. So that feedback needs to be given to the perpetrator. Studies that have been done to understand the effectiveness of therapeutic techniques paints a mixed picture. Some people say that there is no difference at all between people who are treated as against those who are not treated, but some studies show that treatment has an advantage. One such study is done by Hansen and et al., wherein they show that lesser number of treated sex offenders are likely to commit another sex crime than those who are untreated. The Canadian risk-responsive model also shows that we need to look at certain things before we decide on the therapeutic design for sex offenders. So one thing is to look at one thing is to decide who needs intensive treatment depending upon the severity and the intensity. You need to decide who are the patients who require intensive treatment. Then focus on factors that increases the chances of reoffending, as I told you, to look at impulsivity or the presence of paraphilic desire and all of that, and then take into consideration the learning style, motivation and the individual characteristics of these offenders, and then finally decide on this treatment. And this kind of treatment design seems to be better than aversion therapy in itself. There is also existing review of literature which also shows that certain paraphilias respond better to treatment. One study even showed that people with exhibitionism and non-pedophilic sexual arousal have show better success rates than people with pedophilic sexual arousal and rapists. Okay, so we look at biological and surgical treatments. One class of drugs, the SSRIs, are very useful in reducing paraphilic desire and behaviors. The other treatment option that is available is the most controversial surgical or chemical castration, which involves removal of, in a surgical castration, it involves removal of the testis itself. So chemical castration involves administration of anti-androgen steroid hormones such as Depo-Provera and Lupron. And both these drugs are said to cause very serious side effects, but these treatment effects are extremely effects are extremely effective. That is, recidivism rates for castrated offenders are typically less than 3% compared with more than 50% of uncastrated offenders. However, the flip side of chemical castration is that relapse rate upon discontinuation of the drug is very high in chemical castration, but in case of surgical castration we are not thinking in terms of relapse. So there has been a lot of controversy about whether or not this should be used. Despite the apparently high success rates, many individuals feel that such treatment is brutal, unethical, and dehumanizing. Many individuals themselves ask for chemical castration in exchange for a lighter sentence. So some states have made it like a mandate for repeated sex offenders to undergo hormonal therapy as an eligibility to ask for probation or to return to the community. This is again a very debated issue as to whether we'll allow this to happen. There are also people who are against this and saying that because these drugs have side effects, isn't it not unconstitutional to kind of administer these drugs to sex offenders? Now many treatment programs combine hormone therapy with CBT, the hope being that hormone treatment can be tapered off after the offender has learned techniques for impulse control. A lot of problems surround research studies that talk about the effectiveness of treatment for sex offenders. One thing is that these studies do not have a control group of subjects. That is, they don't have a group of people who are already also motivated for change and but are not given treatment. They don't have that. The other thing is that the outcome variable for most of these research studies is that how many of them are really re-arrested for a similar offense of this kind. But this outcome variable is again a problematic one, because not many people who commit sex crimes, their sex crimes come to light. That is, many victims don't report it. Of the reported cases, only half are convicted, and among those who are convicted, only few serve jail sentences. So this again kind of makes it difficult for us to make sense of the studies that talk about the treatment of the effectiveness of treatment for sex offenders. However, one thing that we need to understand, that we have to be very humane in our approach to the treatment of sex offenders, in that we understand that they have an inner tormented life, but at the same time it is a responsibility for us to save the society from very cruel and sex offenders. So that brings us to the end of this video. Thank you.